Okay, I think we'll get started. Welcome, everyone. My name is Dr. Dany Weisz, and along with my co-moderator, Dr. Carolina Michel, it's our pleasure to bring to you and host today the NHRC site presentation. It's a topic that I think is of interest to everyone. It's a little bit mysterious with LV diastolic function and how to use left atrium strain and volumes and measurements in clinical practice. So I think our expert panel today and our outstanding speaker is going to be peeling back the onion a bit and still a bit of a nebulous topic. It's my pleasure to introduce the panelists today. Our first is Dr. Koert de Waal, who's a consultant neonatologist at John Hunter Children's Hospital in Newcastle, Australia. He completed a PhD in central blood flow measurements at the University of Amsterdam and is actively involved in research in neonatal hemodynamics and novel ultrasound techniques, and is probably at the forefront of LV diastology for neonatal intensive care. Our second panelist is Dr. Neidin Bussmann, who's a consultant neonatologist at Cork University Maternity Hospital in Ireland. She completed her PhD involving a research study of the pilot randomized controlled trial of early targeted PDA treatment using a risk-based severity score, the PDA-RCT, which was published a few years ago. And our third panelist is Dr. Ziad Alhassen. He's a neonatologist at Cook Children's Hospital in Fort Worth, Texas, and he completed his neonatal hemodynamics and cardiac intensive care fellowship at Shock UC Irvine. And his research focuses on defining and managing hemodynamically significant PDA and evaluating left ventricular diastolic function in the ELBW population. And of course, it's my great pleasure to introduce our speaker, Dr. Benjamin Ficial. He's a consultant neonatologist and contract professor at the University Hospital of Verona in Italy. And since 2015, he has actively participated in functional echocardiography courses sponsored by the Italian Society of Neonatology and is a trainer of the Italian training program in neonatologist-performed echocardiography. Dr. Ficial, thank you very much for joining us. We're looking forward to your talk entitled Left Atrium, a Mirror of Ventricular Diastolic Function. And thank you so much for joining us, and I'll hand the floor over to you.
Thank you, Dany, and hello, everyone. And thank you for having me. It's a true honor to be here presenting at this NHRC webinar. And I thank you, the moderators, and Dany, and the panelists. I'm going to share my screen. Do you see my screen?
Yes, we can. Thank you.
Thanks. So, yeah, as you said, this evening talk will be about left atrium as a mirror or surrogate of LV diastolic function. And give me a minute just to introduce myself. As you said, I live in Italy, and I'm sure you all know where Italy is. And I live in Verona. I work and live in Verona in the northern part of Italy. And to help you orient yourself, Verona is about 2-hour drive from Venice. No need to explain how great Venice is. And about 2-hour drive from Milan, the Italian capital of fashion and luxury. And there are great things, plenty of things to see in Verona too. Verona was built by the ancient Romans, so is home to many historical buildings. The one you see is the arena and amphitheater, considered even better than the Colosseum in Rome. And for those who like wine, Verona is the perfect place for wine lovers, or for those who enjoy the beach and the water sports. Last but not least, Verona is the town of lovers, the town of Romeo and Juliet. So I hope I've given you plenty of reason to come here visit, and none of whom actually related to neonatology. But I do work as a neonatologist in the NICU of the Verona University Hospital. It is a level 3 neonatal ICU. We provide specialist medical and surgical neonatal services to the western part of our region, Veneto, servicing over 12,000 live births annually. I lead the NPE program in my center. The team is made up of 3 neonatologists and 4 trainees, and we perform approximately 500 echoes a year. So here's the outline of my talk. I'll be answering, or I try to answer 3 simple questions. First, why do we need to assess LV diastolic function? The second one, how should we do it? And the third one, what can we do, at least in a research setting? And I'm going to start with why. I'm going to start with giving you 3 reasons why I do believe it is important to assess diastolic function in our neonates. The first reason comes from my personal experience. Meet Professor Alan Groves. He and his team in London at Imperial College and then at King's College were the first to use cardiac MRI to assess blood flow and hemodynamics in neonates. Specifically, they use phase contrast MRI to measure cardiac output. First, they validated the phase contrast MRI sequences against our gold standard ex vivo flow phantom. And then they provided internal validation by comparing phase contrast MRI cardiac output against cardiac output obtained from end diastolic and end systolic left ventricular volumes. They showed that phase contrast MRI can be successfully applied to assess blood flow in neonates. And I joined Alan's team in 2012, almost at the end of my training in neonatology and pediatrics. And working with Alan was a life-changing experience, and I can never thank him enough. We validated echocardiographic measurements of blood flow, focusing first on LVO and then on SVC. And MRI prompted us to take a closer look at the SVC. As you can see, the SVC area is oval or crescent-shaped rather than circular. And we decided to measure directly the area of SVC from a parasternal short axis view of the great vessels. And then we decided to assess the blood flow velocity from a suprasternal view. So, in conclusion, at the very beginning of my journey into neonatal hemodynamics, I've been focusing on the blood that comes into the heart. And moving on to diastolic function was just a matter of time. It took me 10 years, but it was just a matter of time. The second reason comes from a collaboration, a multidisciplinary collaboration with a close friend, Giovanni Benfari, who is a professor of cardiology, adult cardiology here at the University of Verona. During medical school, I was taught about congestive heart failure or heart failure with reduced ejection fraction. These patients, we all know, have symptoms like shortness of breath, fatigue, and their echocardiograms show a reduced ejection fraction. In these cases, the heart isn't pumping blood effectively into the aorta and systemic circulation. Giovanni told me that recently there is a growing number of patients who have symptoms of heart failure, but their echocardiograms show a normal or preserved ejection fraction. Risk factors include obesity, low physical activity, metabolic syndrome, and systemic hypertension. These patients have a reduced LV compliance and a relaxation, but the heart pumps blood effectively into the aorta, but this comes at the expense of increased left ventricular and diastolic pressure and increased left atrial pressure, first only with exercise and eventually at rest. As left atrial pressure increases, it leads to pulmonary venous congestion, causing pulmonary edema and respiratory symptoms. Over time, these can cause pulmonary hypertension and right heart failure. So the so-called postcapillary physiology is a well-established concept in adult medicine. We know that reduced LV relaxation and compliance lead to a higher left ventricular end-diastolic pressure and increased left atrial pressure, causing postcapillary hypertension. This results in pulmonary venous congestion and pulmonary edema. Over time, it can progress to overt pulmonary arterial hypertension and eventually right heart failure. As you can see, these are the three main mechanisms that determine diastolic dysfunction in adults: an impaired relaxation, which reflects the ability of the cardiomyocyte to quickly store and release calcium; an increased stiffness, because in the case of an enlarged left atrium, you are in the steeper part of the curve, and a greater pressure is needed for the same increase in volume. And finally, the loss of the elastic components in the ELV, which impairs ventricular suction of blood from the atrium in the ventricle during diastole. And our preterm neonates, the neonates we are taking care of, are prone to diastolic dysfunction. They have smaller and less efficient cardiomyocytes with underdeveloped mitochondria, making them less effective at storing and releasing calcium. Additionally, they have an enlarged left atrium, especially in case of a large PDA. And we know that the LV has a reduced elastic component, leading to an impaired ventricular suction during diastole. These are all the ingredients for the perfect storm. And from what I've seen in the literature, there is evidence of postcapillary physiology in neonates. And I'll be presenting two recent papers from the panelists in this webinar. I'm excited that they decided to accept this invitation to participate, and I look forward to hearing their insights at the end of my talk. The first study is by Neidin, and the second one by Koert. I will start with Neidin. They aim to investigate the association between LV diastolic function, measured with TDI, and the coupling between right ventricle and pulmonary vasculature. They recruited more than 160 neonates with a mean gestational age of 26 weeks and a mean birth weight of around 1,900 grams. And they performed a comprehensive echocardiogram on day 1 of life. They found that LV diastolic dysfunction is associated with an impairment of the coupling between the right ventricle and the pulmonary vasculature. The second study is by Koert and is a true pioneer in the study of diastolic function in neonates, as Dany mentioned before. The authors in the study analyzed the echocardiograms performed during the first month of life in 91 neonates below 30 weeks of gestational age. They defined diastolic dysfunction using a combination of echo parameters. And they found that the cumulative risk of LV diastolic dysfunction increased with the duration of exposure to the volume overload caused by the PDA. The results of both these two studies by Neidin and Koert highlight the pivotal role of diastolic function and postcapillary physiology. The last reason comes from my clinical experience. As we've all seen, some preterm babies in our units never leave the unit and they spend their entire life in our NICUs. And I do believe that as healthcare professionals, it's our responsibility to make their lives count and to learn from them, from the experience, from the care we provide to them, and try to continuously improve our care. So baby A was born a couple of years ago by an emergency C-section due to preeclampsia at 28 weeks of gestational age. She had a severe IUGR, But at birth, the transition was smooth. So the apical score was 6 and 8. And she was admitted to the unit on CPAP in room air. In the first hours of life, she had increased oxygen requirements. A lung ultrasound was performed, as you can see, showing a white lung pattern, which is compatible with a severe form of RDS. So she was administered surfactant and was transitioned back to CPAP in room air. At 42 hours of life, she had a massive pulmonary hemorrhage. She was intubated, and she was placed on auxiliary ventilation. She received transfusion of packed red cells and plasma, and she was started on adrenaline infusion. However, despite all these interventions, she passed away a few hours later. Earlier, we performed an echocardiogram exactly at 24 hours of life, which showed a normal cardiac anatomy and a large PDA. I don't want to start a fire by discussing the methods we use in our NICUs worldwide to assess the significance of a PDA. Therefore, please take for granted our institutional protocol, which is based on the NP recommendations. So let's call them the European recommendations. So we assessed the diameter, and the diameter was large, 3 millimeters. And there was a bidirectional shunt with low velocity, and the right to left component accounted for around 30% of the cardiac cycle. There were mild signs of pulmonary overcirculation with an LVO of 220 ml per kilo per minute and LPA diastolic velocity of 0.23 meter per second. And we found diastolic still in the descending aorta. However, diastolic flow in both the celiac trunk and the anterior cerebral artery was normal. So we decided after this echo to closely monitor the PDA, and we did not start any treatment. Could we have done something more? Was there anything in this echo that could have helped us predict the pulmonary hemorrhage? I'm sure I'm not the only one asking these kinds of questions. And I do believe that the ability of a left ventricle to handle the volume overload caused by the PDA matters more than the absolute amount of the shunt itself. And my feeling is that the answer lies not in the systolic function, which, by the way, was completely normal in this case, but it rather lies in the diastolic function. So I hope I've convince you of the importance to assess the diastolic function, giving you these 3 personal reasons. And let's move to how. So how should we do it? It is beyond the scope of this talk to review all the echo measurements of the diastolic function. And there are excellent guidelines and recommendations available on this topic. I think that one of the best for neonatologists is the one published last year on TNE. So I will not be going into details, but rather I just have a quick look. Let's have a quick look at the adult recommendations. So these are the past recommendations for the assessment of diastolic dysfunction in adults. A combination of echo measurements is suggested. However, there is a significant proportion of subjects in whom diastolic function cannot be determined. And what would happen if we used speckle tracking echo? I know that left atrial strain may sound like something complicated, things for echo nerds. However, I do believe that left atrial strain is like the guy in this video. He gets things done by thinking outside the box in the simplest and most efficient way possible. But first, let's take a closer look at the physiology of the cardiac cycle. We are all familiar with what happens to the LV during the cardiac cycle. So with systole, diastole, isovolemic relaxation, and contraction time. But what happens to the almost forgotten LA, left atrium? The left atrium mirrors the LV, doing exactly the opposite. And that's why the title of this talk comes from. During ventricular contraction, LA acts as a reservoir. Blood flows passively into the ventricle, and the LA acts as a reservoir by storing the blood that comes from the pulmonary veins. Instead, during early relaxation, blood flow passively into the ventricle, the MV, the mitral valve, has opened, and DLA act as a conduit between the pulmonary veins and the left ventricle. Finally, in the last phase, the left atrium contracts and actively pumps blood into the LV. Left atrial strain shows all these three phases of the LA, demonstrating a positive longitudinal deformation during the reservoir phase and a negative longitudinal deformation during the conduit and the contraction phases. Left atrial strain reservoir is the most reliable measurement and the one most commonly used in clinical practice, at least for adults. It represents, again, the percentage longitudinal elongation of the LA during the cardiac systole. Its strength lies in the simplicity of using a single measurement that integrates data on both LA function and LA volumes. Using cardiac catheterization, left atrial strain reservoir has been shown to be negatively associated with left ventricular and diastolic pressure. This may sound counterintuitive, but remember, when we have left ventricular diastolic dysfunction, we know that there are increased pressure in the left atrium and usually a subsequent atrial enlargement. And due to geometrical reason, an enlarged atrium compared to a normal one has reduced deformation during the cardiac systole to accommodate the same amount of blood coming from the pulmonary veins. I know that some of you may be still skeptical, but will convince you by showing two clinical cases. So this is a normal baby, a normal term neonate. I think we've done this echo for research purposes. He or she was selected as an healthy control. As you can see, the LV function is completely normal, so we can assume that LV and diastolic pressure is normal and left atrial pressure is normal. And as you can see, left atrial strain reservoir is 45%. Instead, this baby was born at term. At 10 days of life, her parents noticed she was unwell, pale, lethargic. So she was admitted to the unit in shock with a working diagnosis of myocarditis. And she was put on ECMO, VA ECMO support. As you can see, the LV contracts very poorly and the mitral valve barely opens. We can therefore assume that the LV and diastolic pressure is increased and the left atrial pressure is very high. And what about the left atrial strain reservoir? As you can see, it is 7.5%. Did I convince you? I hope so. These are the reasons why left atrial strain has been included in the current guidelines for the assessment of LV diastolic function in adults. However, I acknowledge that there are major limitations of left atrial strain imaging, and the major limitation is the lack of standardization in image acquisition and offline analysis, including variations in software packages and the parameters being measured. So this is Yuri Corsini, a dear friend. He's a neonatologist from Florence, a member of this network, and we are kind of research buddies. So we have done all this together. And we have recently developed a protocol to standardize left atrial strain imaging in order to improve accuracy and reproducibility. We focused first on imaging acquisition and then on the offline analysis. Starting with imaging acquisition, it is essential to obtain a high quality, not foreshortened apical four-chamber view with a high frame rate. We explored different options for image acquisitions. So apical four-chamber view, apical two-chamber view, and apical three-chamber view. We excluded the three-chamber view because, as in adults, the aorta, the wall is too close to the wall of the left atrium, making it difficult to separate them. We then compared biplane left atrial strain obtained from both the four-chamber and two-chamber view with monoplane left atrial strain obtained only from the four-chamber view. At least in our cohort of neonates, we found an excellent agreement between biplane and monoplane left atrial strain. And from a practical perspective, these methods appear to be interchangeable. However, due to the superior feasibility of apical four-chamber view compared to the apical two-chamber view, at least in our hands, we decided to include only the calculation of monoplane left atrial strain in our protocol. So to summarize, we need to obtain an optimized, not foreshortened, apical four-chamber view with a high frame rate, the ECG on it, and then we can calculate the monoplane left atrial strain. Moving to the offline analysis, it is essential to use a software with a dedicated LA option. We cannot use the LV option to analyze the strain of the atrium. We use Tomtec, and I find it excellent for this purpose. And the major advantage is its ability to work with clips from different scanners, making it intervendor compatible. As recommended in adults, we selected the QRS as the starting point, as the reference point for the LA analysis. This approach simplifies the calculation of left atrial strain reservoir. As I mentioned, the most reliable and likely useful parameter. So, having developed a protocol to standardize both image acquisition and offline analysis, we applied this protocol in a second cohort of neonates in order to establish reference ranges for LA strain measurements during the transition. And we demonstrated in a subcohort of neonates a good intra-observer and inter-observer reproducibility. So, to summarize, left atrial strain imaging has a good feasibility and reproducibility. And by merging our data with those from Koert, normal values of left atrial strain reservoir are 32% in day 1 of life, 36 in day 2 of life, and more than 40 thereafter. And remember, low values of left atrial strain reservoir are associated with high left atrial pressure. Let's move now to the final part of this talk. We've understood why it is important to assess the diastolic function and how to do it. So let's put this knowledge into practice and start doing it for real. At least, again, in a research setting. We've started with TTN. Yuri and I thought it was easier. And we wanted to test our hypothesis that the heart could play a role to explain the respiratory symptoms in these neonates. Here you can see a typical chest X-ray of a neonate with TTN and a typical lung ultrasound pattern showing the double lung point. And I recommend you guys this review by Ziad on the pathophysiology and management of TTN. Although the pathophysiology is not well fully understood, a delayed clearance of lung fluid plays a central role. And we wondered if an impaired LV relaxation or diastolic dysfunction could contribute to TTN. So we wondered if these babies with TTN had an impairment of LV relaxation causing increased left ventricular and diastolic pressure, increased left atrial pressure, therefore pulmonary venous congestion and pulmonary edema. So this is our research question framed according to the PICO framework. So in neonates again with TTN, defined by clinical and ultrasound criteria, with a gestational age between 34 and 39 plus 6 weeks. Does an comprehensive echocardiographic assessment show an impaired diastolic function measured with left atrial strain and the conventional measurement of diastolic function, compared to a healthy controls matched to cases by GA and sex? This was a multi-center prospective observational study. We included 27 neonates with TTN matched with 27 controls. And a lung ultrasound and a comprehensive echocardiogram were performed at 2, 24, and 48 hours of life. As you can see, in both the TTN neonates and controls, we observed a significant increase in left atrial strain reservoir over the study period. However, left atrial strain reservoir remained significantly lower in neonates with TTN compared to controls, resulting in a statistically significant group by time interaction. The reduced left atrial strain reservoir observed in neonates with TTN suggests, in our opinion, the presence of a diastolic dysfunction, which may explain the delayed clearance or at least contribute to the delayed clearance of lung fluid. This difference is not detected by the E prime ratio. The same is true for GLS, for global longitudinal strain, that was normal over the study period in both cases and controls. Instead, we found that the PAT-RVET ratio, an index of pulmonary vascular resistance, was significantly lower in neonates with TTN compared to controls at 2 and 24 hours of life, normalizing by 48 hours of life. These findings align with postcapillary physiology, where an increase in left atrial pressure leads to elevated pulmonary pressures. In conclusion, this is the main finding of this study. So we found a decreased left atrial strain reservoir in neonates with TTN compared to controls over the study period, suggesting the presence of diastolic dysfunction, which may play a role in the delayed clearance of lung fluid. We acknowledge that this is an observational study, and so we cannot establish causation. However, I do think that there is a biological plausibility of the diastolic dysfunction in this category of patients. And what's next? I've had the opportunity to reconnect with Professor Willem de Boot, and I think everyone knows him. And we've started a research collaboration. And I'm sure that with his invaluable experience, and let's call it with his hemodynamic wisdom, he will be able to guide me as I continue to explore the complexities of diastolic function. And I'm absolutely thrilled to have Professor Guttin and Professor De Waal on board with me too. So what we are going to do, we want to explore the role of diastolic function in PDA, RDS, and BPD. I know it's definitely an ambitious project, but I'm excited to see how things unfold. It will certainly not come over the night. It will take some years, but here we are. To wrap up, these are the key take-home messages. First of all, postcapillary physiology is a well-established concept in adults. Why wouldn't the same apply to neonates? And diastolic dysfunction in newborn is a relatively new concept, but is likely more common than currently recognized. And again, left atrial strain can help us gain a better understanding. But please, to be on the safe side, don't try this at home. I want to take a moment to say that I'm not alone. I wouldn't be here without the help of an amazing group of friends, all of whom share the same passion for neonatal research. So thank you all for being such an important part of this. And finally, a special thanks to my beloved wife and colleague, Elena, and to my kids. Without you, none of this would be worth it. And thank you all for listening.
Thank you, Dr. Benjamim, for this amazing and novel talk. I want to remind to our audience to please write your questions on the Q&A. While we wait for that, I'm gonna start by asking you related to the case you described before. The baby had severe LV systolic dysfunction. So how do you disentangle the relative effect of systolic versus diastolic dysfunction on LA pressure?
It's a great question because it's really hard to differentiate between the diastolic and systolic component. However, I do think that when we look at diastolic function, and I'm sure Koert could add on this, we do this to identify babies with an impairment of myocardial performance before they have a systolic dysfunction. So our aim is to early identify these babies with a myocardial impairment before they develop a systolic dysfunction. And it is likely that neonates with only diastolic dysfunction may have some problems, may be related to pulmonary respiratory symptoms, like in these babies with TTN, that they have respiratory symptoms, they have the so-called wet lung, and usually they don't have any symptoms related to heart failure or shock hypoperfusion. But maybe they have some kind of impaired relaxation that exacerbates during the transitional period due to intrinsic properties of their heart. So when you have a baby with a severe myocardial dysfunction, both systolic and diastolic, I do not think it is essential to assess left atrial strain imaging and left atrial strain reservoir. I mean, these are tools we are using in a research setting. We are still far to apply these tools in a clinical setting. But again, this baby on ECMO, I've tried I just, for this talk, just for the purpose of this talk, I took the images and analyzed them on my workstation. And, it is shocking how accurate these tools are. So let's apply these tools in a research setting. Let's gain some experience, and then let's move all these tools and all we have learned to clinical practice. I hope I answered your question.
Yes, thank you so much. So I'm gonna continue with one question, which is on the Q&A box for you or anyone in the panel. So any comments to take PFO or ASD into account for LA strain?
Okay, this is a great point. So it is true, actually, one of the shortcomings of left atrial strain imaging is when you have a big ASD rather than PFO. So when you have a big huge defect in the atrial septum, left atrial strain is not that accurate as we hope. However, it can be applied. Again, we are talking about research. We are not talking about measurements that, at least now, are changing our clinical practice.
Can I add to that? First of all, Benjamin, fantastic overview. And I really appreciated the part about acquisition and analysis in your paper as well. That's highly recommended for people to read who starts with this. I think it is ready for clinical practice. I'm already using left atrium strain, and the concept, as Benjamin describes, are very important. There's different left ventricular diastolic pressures. There's a minimum pressure, which starts somewhere end systole, and there is an end diastolic pressure, which is at the end of diastole, and then the mid diastole, which is actually maybe not even left atrium strain in reservoirs, maybe conduit strain, and Neidin did some work on E prime, which might be more important in that particular aspect. And the combination of it all can describe what happens during diastole and whether left ventricular pressure is raised or not. And the adults actually found that with normal GLS, with normal left ventricular function, you have to have really low left atrium strain values to say that left atrium pressure is raised. And there is this gray zone where you have to use other parameters in combination. And this multimodality approach is probably the message which comes from the adults. How to use it in practice and which patient population, the first question, if you have a very low systolic function, I totally agree with Benjamin. Just focus on the systolic function and get that one better, because diastolic function will be abnormal. And then the patients where actually have normal systolic function, that's where we can gain the most to see that they hopefully do not progress to systolic dysfunction, and see if we can find some treatments there in between. So that's my sort of summary, and thanks, Benjamin, for this overview.
Thank you, Koert.
The question to add, thank you so much, Benjamin, for an absolutely fantastic talk, and looking forward to the discussion with our panelists. Before we move on, Koert, I did want to ask you, I know you had spoken about, and thank you, Benjamin, for going through some of the ECHO criteria used. And the adults, they do set fairly clear parameters of what's normal versus abnormal. And what certainly I personally struggled with is what E over E prime do I use for neonates, especially for the preterm babies? And secondly, for LA volumes, we're just getting to the understanding with some of your work about what's normal versus abnormal. But could you, either Benjamin or you or Koert, could you help us understand what are the thresholds or potential thresholds when trying to apply these parameters for our preterm babies with normal systolic function, but who we suspect that there's diastolic function contributing to increased LA pressure. What are some thresholds? They can be general, of course, but for some of the parameters that you've spoken about that can help us start to introduce this into our clinical practice, or at least think about it as we're doing these measurements.
I can have a first go, but look, very important to realize gestational age group. There's difference between the very young ones and the term babies and the in-between ones, which I don't think we have much data on. Then postnatal age. So what happens in the first 3 days, Benjamin's data is awesome because that's probably, you know, actually sequential over time, and you can see the changes even in the normal population. And in the preterm population, there's difference between sort of the first couple of weeks versus at discharge. Those are the two moments which we generally screen babies for all sorts of things. And there are absolutely different values to apply, unfortunately. One of the best thing about left atrium strain, it doesn't change that much. And if you want gross parameters, less than 18%, absolutely abnormal, most likely high left atrium, left ventricular filling pressure between 18 and 25, gray zone, a little bit dependent on the other parameters, and over 25 to 35, I would say you're in the normal range, more likely, and particularly over 30, you're in the normal range. So those will be gross parameters, and they actually are throughout postnatal age and throughout gestational age, except what Dany said, what Benjamin said, is that when you're a term, you can have slightly higher values.
Yeah, I do think that, Dany, you raised a great point. It is so hard to have normal ranges or reference ranges in our population that is intrinsically abnormal. Therefore, you need or great cohort studies, and we don't have these great studies with great numbers of neonates. Either you do need to associate these numbers with clinically relevant outcomes. And again, we still need to do these kind of studies. However, I do agree with Koert. So at least, you know, approximately, you can use these reference ranges for later strain reservoir in neonates, the reference ranges Koert mentioned. In our unit, we do perform global longitudinal strain to assess the systolic function in the clinical in clinics. So and we do have reference ranges. However, we do not still use left atrial strain imaging in our clinical practice. We do it only for research, but my feeling is that, again, less than 25, you should take a closer look to it. Over 30, over 35 better, you're okay.
Maybe Neidin, can you comment on the E prime? I use 2.7, 2.8 as abnormal, but that's in the first, you know, couple of weeks in preterm infants. What do you use for E prime?
So it varies depending on whether there's a duct present or not as well. That's going to affect. So I actually use the reference ranges that Aisling Smith had published there with the FIF a few years back. I find them extremely useful. I actually have them on my phone. I pull them up when I'm doing an echo, and I will refer to them because I don't have space in my brain to remember exact numbers, I won't lie. And it varies depending on day 1 and day 2. It varies on preterm and term infants as well. And for me, it's never one individual number. You know, there's going to be a lot more signs of some dysfunction than just one individual number as well. I'm fascinated by this, Benjamin, and I think this was a really, really good talk. You did distract me initially because I was looking to book flights then to go visit everyone in Verona, rather than listen to your left atrial strain. But look, I would be really fascinated to look at the 2 cohorts that I'd looked at historically. So let's say the cohort where we looked at increased respiratory morbidity in preterm babies with poor diastolic function. Would the left atrial strain also be an early indicator for the need for invasive ventilation in these babies, and also pulmonary hemorrhage, which it's something that can be very devastating in the neonatal unit, and it sets babies up for multiple issues down the line, not just acutely. So if you had a very simple parameter like left atrial strain that you could do at the bedside in a baby in those 24 hours, you're assessing the duct potentially as well. You may not extubate that baby as you had previously thought that you were going to. And again, I know this is something that's not clinically applied in many units, and certainly we're just starting to look at it ourselves. But I'm honestly fascinated. And then the other cohort I was really interested in is the PDA group. So do you think, like in adults, again, I was just reading around this a little bit in preparation for today, and I saw in adults with heart failure that the grade 1 and 2, they might not have any left atrial volume changes initially, whereas 3 and 4 will. But then if you were to look at left atrial strain in the grade 1 and 2 heart failures, they have significant abnormalities. So it's really if this marker is one that's going to tease out the babies that aren't very obvious, because they're the ones that we don't want to miss, then that'd be fantastic. Are you going to be able to pick out on day 1 or 2, this baby's duct is very significant, their function is very poor, they're not going to cope with increased pulmonary blood flow, they're not going to cope with increased left ventricular overload, and they're going to get very sick. We need to close this duct, and if it doesn't close with paracetamol, ibuprofen, whatever you're using in your unit, then it's a device closure. They're the kind of things that were kind of going through my mind as you were talking through it. So I'm very excited to see what your group comes up with the looking at left atrial strain in PDA, RDS, and BPD. Yeah, so really, really exciting, Benjamin. So keep us in the loop, please.
Thank you, Neidin. And I can't remember it, I'm not sure if I remember correctly, but looking at your PDA score, I think that in your PDA score, there is GA, birth weight, maybe, and the E prime. And I think that E prime plays a major role. I'm not an expert of regression lines and logistic regression, but I do think that the E prime, when I look at your paper.
Interesting. It was actually A prime that we used, because A prime was more statistically significant. And at the time, when I was using it, I questioned, why are we using A prime? It's that atrial kick, what's that got to do with ventricular function? But now looking at all of this coming out with left atrial strain, the pieces are actually really falling into place. So yeah, LVA prime is what we looked at for the PDA score.
And what would happen if you use left atrial strain instead of A prime?
It'd be interesting.
It could be really interesting. And first things first. So early identification of these babies is the first step we need to tackle.
Yeah, I agree. Even you could look at a cohort of patients, and you could use the PDA score, and then you could just use LVA on its own, and just see how that correlates. But yeah, it's very, very interesting, Benjamin.
Thanks. I think Ziad, you had a comment, and hoping also to hear your thoughts on integrating this in assessment of babies with PDA, as we've discussed.
Yeah, thank you so much, Benjamin. That was an excellent lecture. I really enjoyed it. The case you presented really hit home for me. I had a baby with severe pulmonary hemorrhage, and in retrospect, I was reviewing the echoes and noted that the baby had some signs of LV diastolic dysfunction. In my baby in specific, had a very restrictive atrial level shunt, and kind of like the opposite problem of what we talked about before. But I guess my question to you in the group is, how much of a role does the size of the atrial level shunt have on atrial geometry and strain? And is that something you look at when you're doing your studies? And how much of a role does that play in increasing the risk of developing a pulmonary hemorrhage in the setting of LV diastolic dysfunction?
Maybe Neidin, could you comment, just to refresh us on your prospective study and identifying the respiratory morbidity associated with diastolic dysfunction?
Yeah, I mean, with regard to Ziad's question about the atrial, it was essentially an atrial septal defect or a PFO and the effect. Is that right, Ziad?
That is correct.
Yeah, I can't say that we looked at that specifically for our cohort. Like our thinking process was always that, you know, similar to what Benjamin described, with reduced ventricular diastolic function, reduced relaxation, back pressure onto the left atrium, back pressure onto the pulmonary vasculature, leading to congestion and essentially a massive pulmonary hemorrhage. But it'd be interesting to look and see whether an atrial flow, whether that affected it. I can't remember that we did look at that, Dany, unfortunately.
There's other factors involved here. When you look at atrium volume, first we need to measure atrium volume. LAL ratio is not going to cut it there, and we really need to let go of that particular parameter. So first we need to know the actual volume. It does get nice and round, the left atrium, particularly when it's really dilated and it angles from the left ventricle. So you need to focus your image acquisition on that. And then you have measurements which can actually measure left atrium stiffness. So those are different parameters which you can grab from sort of the adult world too. That will be interesting to look at: foramen ovale size, left atrium volume, and left atrium stiffness in combination to see if there is changes there. I haven't looked at that, but that would be, it sounds like an interesting study. I'm in.
Can I actually ask a question about the image acquisition while I have all the experts on the line? I was doing a little bit of reading around it, and just with regards to the pro-positioning. So I suppose what you don't want is atrial foreshortening. So you don't want to lose the atrium. But the problem is when you're doing your traditional 4-chamber view and you're trying to avoid ventricular foreshortening, you may inadvertently cause atrial foreshortening. So how do you best assess the quality of an image, I suppose, when you're not the person at the bedside doing it and you're just looking back at it?
Yeah, it's not easy. It's not easy. Actually, my suggestion, I don't know you, Koert, is to slide the probe slightly to the patient feet and tilt upward more, so you can get the atrium in the correct plane. Because as Koert mentioned, the left atrium and the left ventricle are on different planes, and it can help just slide the probe a little bit down and then tilting upward a little bit more, and you get a good view of the left atrium. That's why we, in our protocol, we chose to, and in our image acquisition protocol in the unit, to acquire and optimize, let's call it optimized apical 4-chamber view for the LA strain imaging assessment offline. Because sometimes,
good points, Neidin. If you're not there, you might not know. But
Yeah,
if you're there, you do what Benjamin is saying. You make a 4-chamber image focused on the left atrium, where the left atrium is the biggest, and sometimes that will include foreshortening of the left ventricle.
Yeah, so and I wonder, like, if you have foreshortening of the left ventricle, you're nearly more reassured that it is a good image for the left atrial strain. But
another one is, if you can see the appendage well in a dilated left atrium, you're generally, not always, we're generally in a good plane for the left atrium maximum size. But in a small left atrium, well, Benjamin has more experience with his term cohort. I still find it challenging to do the very small left atriums. How do you do that, Benjamin? The small left atrius. How do you focus there? What do you focus your eyes on?
Actually, my trainees do it. But to be honest, they are so scaled that I've almost forgotten. But now, apart from joking, yeah, it isn't easy. It takes time, and you need to carefully acquire different clips. And then in the offline analysis, you can pick the right one, the one where the left atrium
Sure.
is bigger, as I mentioned. Once we try to, put the HD zoom on the LA and just, acquire clips with just the LA, but that option didn't work. So we came back to apical 4-chamber view, classical apical 4-chamber view, just focusing on obtaining the largest atrium possible. And sometimes I'm not saying you are in, you use this plane window, you are there. So you are down in the belly, tilting upward as you can to get the atrium in the right view, in the right plane. But
sorry, Benjamin, go ahead.
yeah, but again, left atrial strain is a tool, is a good measurement. I do believe on it. However, there are issues on reproducibility. You are not doing all the same things. I'm pretty sure about it. Even if when we compared our data with Koert data, even if I'm in Italy and he's in Newcastle, numbers are pretty similar, are not the same, but are similar.
Yeah, that's very reassuring. And do you think there'll be like at the moment this is it's all offline analysis. Do you think there'll be an automated left atrial strain analysis at the bedside? Like I believe they're doing that in adult patients already, isn't that right?
For sure. When I started, it was like 2017, and we applied the LV option to assess strain, assess left atrial strain, and it didn't work at all. And then we've seen, the first LA option, and then we tried it, and everything worked in adults and in neonates. And now I've tried just once, a semi-automated option to assess LA strain in neonates, and actually it worked. So I'm sure, that improvements in technology and in softwares and AI and blah, blah, these will get things right in the upcoming years.
I have one last question just to pick your brain as well then, Benjamin. What about left atrial strain rate? Is that something that you've looked at, or is it all about the strain?
I'm not sure, if everyone agrees with me, but I'm finding tricky left atrial strain rate even in the LV, and I find it very messy in the LA, and even differentiation between the LA strain contraction and conduit phase is hard because the P wave we have is just from 3 little leads in the neonate test, and we cannot rely on that. And I don't think left atrial strain is an option now. At least in our hands, the reproducibility is very low.
Okay, yeah, it's good to know.
With the technical question, I had one more, which is for some of the babies with truly a very severely enlarged left atrium, the confluence of the pulmonary veins seems to have kind of a bit of an outpouching. Are there any technical issues with trying to accurately estimate strain in that setting where the confluence of the pulmonary veins seems to somewhat detached or ballooned out from the rest of the left atrium? Question for anyone.
Okay.
Look, so yes, and we came to this, analysis at the bedside where your screen is smaller, you have less options. So I'm a big fan for offline analysis, even for simple, TDI, etc., to do it more accurately offline and get a good assessment and slow motion and a big screen to let your eyes sort of get used to that little heart. So the complications, the gaps is the appendage, where it can be a big gap, which is black, which of course cannot be speckled. And then you have your pulmonary vein either on one spot or usually on two spots, where particularly with large enlarged left atriums can be a gap. The advantage of the left atrium strain package, it's only three areas. It's the roof and then the sides, and you can sit the different dots at different places, and you can cover that gap. I must admit, the bigger the gap, sometimes the bigger the problems, but that's the detail which has to be, which is required to do left atrium strain sort of properly. So you work with these little dots, you put them on different places where the machine can still recognize, and then in between those gaps, it will take sort of the differences between systole and diastole. So it can be, if you use the automated function, you will go wrong. But if you manually adjust all those particular places on the right spots, I find that left atrium strain packages nowadays are pretty good. And the newest one, TomTech doesn't exist anymore, unfortunately, so there's no Philips ultrasound workstation, but that one works really well. I don't know who works with the newest of GE. I haven't worked with the newest of GE LA package, but I bet some of you do. And I agree, the newer the software, the better they get. They are really, really good. They used to be crap 10 years ago, but now they are really good.
And I do agree with Koert. But again, then it can be tricky to use LA strain in some particular cases. But over time, you learn how to use it.
Maybe a simple tip for people who start using this. You take one user who does the measurements, and then you take a second user who does the same analysis on the same patients, and you do a blend Altman with each other. And you then look at the outliers and go sit again to say, what did you do different? Where did you put the dots? And then you get closer together. That doesn't mean that you're doing the best or, that's the gold standard, but at least within your unit, you're all being setting the dots and the gaps on the same place. So your strain measurements will be quite comparable between users.
And you can publish a paper.
You can, yeah. And we will.
Thank you so much. So I have a question. It's more like clinical for everyone in the panel and Benjamin. So how does these echo findings of diastolic dysfunction can modify your management? This is personal, but will you change the threshold for treatment of systemic hypertension, for example, or will you start right away to treat if you see this diastolic dysfunction?
Yeah. Great question, and you are definitely right. Okay, great stuff, great things, great research, maybe, but when it comes to a sick neonate, what can we do? I believe that in the upcoming years, we will apply left atrial strain imaging and assessment of diastolic dysfunction in neonates with BPD. We don't know sometimes how to treat these babies. A recent meta-analysis has been published on diuretics. And again, we don't know which diuretic to use and if they actually work. However, there is an increasing number of data on neonates with BPD and the so-called postcapillary pulmonary hypertension. These are babies with respiratory symptoms, severe or moderate forms of BPD, and hypertrophic LV, systemic hypertension, and diastolic dysfunction. I do think that these tools can help us, define the phenotypes of babies with diastolic impairment and with BPD, and maybe we would choose, let's say, captopril rather than sildenafil to treat pulmonary hypertension in these babies. And I don't know if someone of you experienced, but there are babies that when you start them on sildenafil, they have a sudden deterioration of respiratory symptoms because, you know, you increase the amount of blood going to the lungs when their real stop is not in the pulmonary vascular resistance, but it is in the LV and in the ability of the LV to relax and to, you know, to relax and to dilate. So I do think that the first clinical application of these enhanced diagnostic tools will be in the setting of BPD. I'm not sure how these tools will work in the PDA setting because we don't know, at least we don't have a treatment of PDA that shows some improvement in outcomes. So I'm looking forward to apply these tools to study the diastolic dysfunction in babies with PDA, but I'm not sure that we will see in the next years a treatment or application that will change our clinical management. But I'm pretty sure that in BPD, we will see treatment changement in treatment and in management applying these tools.
Thank you, Ben. There's one more question in the Q&A, and then I think we'll wrap up. And this question we'll send to Koert. And the question is, do the measures of LV diastolic function and LA strain, do they influence the definition of pulmonary hypertension of the newborn?
Yeah, I thought it was a really good question because I think there's been some confusion which is created by us because the pulmonary physicians talk about postcapillary hypertension and the cardiologists talk about diastolic dysfunction. And you could argue, you know, aren't they the same? You know, where is the pressure raised and what is the actual cause of it? So this is a part of the confusion which we all are part of, that we are not using uniform terminology, which can be confusing. But Benjamin has explained that, you know, pulmonary hypertension is part of diastolic dysfunction. It's the pressure down the tract which is raised to make sure that the blood flow remains the same. So you can have pulmonary hypertension due to diastolic dysfunction or postcapillary hypertension. I think that's probably the concept as an answer. You know, does it change your definition of what is pulmonary hypertension on ultrasound? No, it doesn't. But you have to realize that some of the pulmonary hypertension, we always think about, you know, that must be pulmonary arterial hypertension. And the difference there is you would have a small left atrium, while if you have diastolic dysfunction, you will have a large left atrium. And I think that's just a simple way of looking at pulmonary hypertension. Same ultrasound parameters on your TR or your septal deviation or even your PDA flow pattern, that you still have to look at the left atrium. If that's very small, it's more likely to be pulmonary arterial hypertension. While if the left atrium is really big, it is certainly possible that this is actually diastolic dysfunction, which both of them require very different treatments. One is pulmonary vasodilators, or it makes sure like nitric oxide or something like that. And the other has to actually not do pulmonary vasodilators because it can make things worse. And I think that's the concept I like to explain. Thanks for the question.
Thank you, Dr. De Waal. So thank you, everyone. I think we're gonna finish here. This was a very wonderful session. Thank you, everyone, for attending, and see you next time.
See you next time. Thanks, Benjamin.
Thank you, everyone.